morning, everyone. This is the San Diego Spine Foundation lecture series. And today we're super excited to have Gautham Prabhakar speaking to us about proximal junctional kyphosis. Gautham is one of our fellows, is coming in from UT and at a center where his boss, Jeff Hills, has been one of the young surgeons that's leading the way in this field. So I'm really excited to hear from Gautham. And Gautham, do you want to give us maybe like three of your take-home points from the talk today?
Yeah. So as you all know, proximal junctional kyphosis, or PJK, is something we're all faced with in the world of spine surgery. So I think the three takeaways is, how do we identify this and diagnose it? What's the algorithm of going through managing these sometimes devastating complications, and what does the future hold for PJK, and where are we going with this? So I think those are the things that we're going to run through today and discuss.
Awesome. Well, without further ado, looking forward to your talk. Thanks, Gautham.
Yes, sir. Thank you. Today we're going to be talking about, something that's super important for anybody in spine surgery. Despite great efforts, PJK still remains an arch nemesis for us, especially for the deformity surgeon like Dr. Mundis. This bad guy is pretty hard to beat, but we're definitely getting closer as more research is going into this and thought process is going into this. And we'll review some of the literature and present some of these new developments that are currently ongoing. Okay, so we'll go through definition, incidence, some risk factors, clinical implications, and prevention and treatment of this important complication. And especially important to know is that we are seeing more and more PJK because of the aging demographic and some of those early spine surgeries years ago where not so much thought was put into alignment, and unfortunately, there was a fair amount of flatbacks causing, sequential problems. So, but I think that number, as the newer generation of spine surgeon comes out, hopefully that number decreases as we're planning more and getting better at addressing proper alignment. So, as we all know, treatment of deformity requires a lot of planning, especially when it's deemed to be a surgical problem. It's usually going to require long segment instrumentation and fusion. So some definition, we usually say that PJK is 10 degrees of kyphosis at the top compared to the preoperative kyphosis at that segment. And radiographically, this can be a finding that doesn't necessarily have symptoms, but when it becomes problematic, it can manifest as pain, which can be from various causes, such as the disc space breaking down, postural deformity through collapse, kyphosis, stenosis, or instability from the ligamentous complex attenuation or disruption, and sometimes even fractures through the body. When surgery is required, you typically do extend the fusion proximally and try to correct that deformity at the level it's failed. So here are the most common definitions. As I said, UIV and UIV plus 2 of at least 10 degrees and at least 10 greater than the preoperative measurement. And of course, we have proximal junctional failure, which is along that same spectrum, which is basically a coincidence of PJK with fracture of the UIV or UIV plus 1 and disruption of the posterior ligamentous complex. So here are the important papers addressing this issue. The most commonly cited one is the Gladys definition from 2005. This stated that Cobb angle should be greater than or equal to 10 degrees between the UIV and the two superadjacent vertebrae compared to the preoperative measurement. The Gladys study here is from WashU. I believe it was 2005. And they basically compared preoperative and final postoperative radiographs and correlated them to SRS-24 outcome scores. They looked at 81 adults and found that 26% developed PJK. The average Cobb measurement was 19 degrees, and stopping at T3 in their series had the highest amount of PJK, or highest rate of PJK. The incidence overall varies in the literature. It can be anywhere from 17 to as high as 62%, but in this series, it was around 20 to 40%. The timing of PJK is also something to note. 80%, at least in this study, occurred within the first year and a half. And again, the wide range in incidence is due to it being a complex problem with significant contributing risk factors. One 2018 study, sorry, where is this? Yeah, one 2018 study followed 34. I think one of the slides are missing. Interesting. Okay. Anyway, so this study with 314 patients for 2.5 years, and they had a rate of PJK of 25%. And looking back, the risk factors that they identified were age over 50 and a higher BMI. Surprisingly, their cutoff was quite low at a BMI of 25. And then, of course, higher preoperative pelvic tilt had a positive correlation with PJK occurrence. Despite 28% incidence, only 2.3% underwent revision. And of this 2.3%, only 15% of those were actually for PJK. So in this study, at least, it was actually a relatively low revision rate. The other causes for revision were symptomatic stenosis or infection. This was a study in 2016, a meta-analysis of 14 studies with over 2,000 patients. And they had an average PJK rate of about 30%. And they had several forest plots that they provided identifying some significant risk factors such as age, long fusions ending at S1, prior kyphosis, specifically at T5 to T12, low bone mineral density, and preoperative sagittal imbalance over 5 centimeters. The most significant odd ratios in this particular study was age, thoracic kyphosis, and SVA greater than 5. So generally, we categorize risk factors into 3 groups. So radiographic or preoperative radiographic measures, which kind of gives us a sense of what kind of imbalance and biomechanics are at play. Patient-related factors, which gives us a sense of their native biology and their healing potential. And finally, surgical risk factors, and that kind of directly correlates with technique and what we do as surgeons in the operating room. Radiographically, sagittal alignment is taken into careful consideration, and choosing the UIV remains controversial and is influenced by a number of factors. We look at patient health, comorbidities, and then, of course, surgeon-specific decisions like approach type and constrict rigidity, number of rods, fusion level, how much correction we actually need, and the goals for global alignment. All of them require a significant preoperative planning. So, again, as I said before, PJK was thought to be just a radiographic finding, something that just happens postoperatively. But now we realize that clinically it can actually pose a significant problem and be a huge pain for the patient. And again, it exists on a spectrum. So from benign disc changes to complete failure with fracture, instrumentation pullout, neurologic symptoms, and fatigue with worsening posture. This can all occur with this complication. So of course we have to do our best to understand this and hopefully prevent it. So again, this was a 2013 study by Hanjo Kim and colleagues looking at upper back pain as a marker for PJK. And what they found was that no patients without PJK had reported upper back pain. So basically, upper back pain is fairly uncommon problem for patients with no radiographic issues. 30% of the patients who did have radiographic PJK had some level of upper back pain. So again, as we said before, not all PJK will have symptoms, but as high as 30% can indeed present with some level of kind of thoracic pain. So clinically, when we're examining the patient and taking their history, we should definitely keep this in mind. In response to this, strategies to mitigate the risk of PJK have been greatly debated. They're becoming more discussed, more thoughtful about different strategies. So some things that may come into play here are things like vertebroplasty augmentation or cement augmentation. And again, we have to kind of be mindful about the different costs, as any kind of revision has a significant economic burden. So we got to do our best at reducing the cost of revision surgery and making it efficient and helpful. Yeah, as high as $75,000, and this was back in 2008. So I imagine it's higher now. So in terms of classification systems, one was proposed by Yagi and colleagues. They talked about three different types of PJK, particularly the ligamentous failure type, bone failure type, or implant bone interface failure. They then subtyped by kyphosis and spondylolisthesis. And interestingly, in their series from the complex spine study group, adjacent segment disease was reported at only 1.4%. And out of these nearly 1,600 patients, only 23 had PJF. The most common failure mode was fracture at the UIV plus one. And the largest risk factor that they found was a larger degree of sagittal correction between pre-op and post-op. Another classification by the SRS Adult Spinal Deformity Committee graded PJF severity based on symptoms. These were specifically neurologic deficit, pain, instrumentation failure, kyphosis, and fracture. Their goal was to develop a score to help guide treatment, although unfortunately there wasn't a strict consensus on what score necessarily kind of leads you towards intervention. Other prophylactic measures, we did talk about cement augmentation, but we also have to talk about hook constructs, as we've definitely seen these, in some of our patients. And the theory behind this hook construct is to basically kind of soften the landing zone and thereby creating a less abrupt transition. There's also some theory towards undercorrection rather than overcorrection and the idea of age-adjusted targets, but there's a lot of debate on this because age doesn't necessarily tell us the overall picture, and it doesn't necessarily incorporate degenerative changes for that particular patient. And I think this is something that my mentor in San Antonio, Jeff Hills, Mike Kelly, and all their group kind of told us with their mean studies. We got to be correcting patients to normal. You wouldn't try to treat a heart patient or a cardiac patient and try to get them to, another diseased heart patient. You would want to get them close to a normal patient. And so that's what we are trying to do, making spine surgery, particularly deformity surgery, more personalized and more individualized. And hopefully this gets us to a better target. So other risk mitigation strategies, of course, includes assessing bone health. Bone health is paramount to obtaining a successful outcome. If we go ahead and do these surgeries in patients without optimizing their bone health, it's doomed for failure in PJK and PJF. So Hounsfield units, they're pretty useful, although they're imperfect, an imperfect marker for bone health. It can help you determine things like maybe should I upsize my screws? Do I need to augment in any kind of fashion? And of course, there's also some exciting research involving finite element modeling and biomarkers for planning, surgery and bone health. So emerging evidence from endocrinology literature has shown promising treatments on the very things that we're using today, like teriparatide or Forteo, that we're using in fragility fractures. And so using these drugs in these patients has definitely had an impact on our patient outcomes. So this study here, this was a study of 43 patients versus 33 controls. They had, female patients, and they did show reduced PJF rates when used post-operatively. And this was possibly due to improved bone strength and enhanced fusion. And minimum 2-year follow-up definitely gave us some long-term insight into this. Yeah, regarding hooks, so prior to the widespread use of pedicle screws, hooks were commonly used in AIS patients. Hook-only constructs attached to the TP at the UIV have shown lower incidence of PJK, almost 22%, compared to pedicle-only constructs, 35%. Although these studies have kind of small sample sizes here. Um, yeah, one study here by Kim and colleagues, 410 patients with 3 different constructs, and their hook-only constructs, hybrid constructs, and pedicle screw instrumentation we can see here. And at least in this particular study, they did show that their PJK incidence was lower with a hook-only construct. So risk calculators have tried to stratify the importance of known risk factors. Most are trying to do an estimate of estimate aspects of global sagittal balance. For instance, needing to do a PSO often implies a bad mismatch pre and post-operatively. SVA and changes in thoracic kyphosis have been significant in some other studies, and trying to look for this study. Yeah. And some studies have shown that preoperative flexibility testing may be crucial when we're planning for deformity surgery. And this is to see whether the thoracic spine can actually compensate for a sagittal correction. As if they do not, then you may have to do a thoracic osteotomy or, of course, choose a higher UIV. So definitely, utilizing flexion extension films and, sometimes utilizing supine and standing films and taking into account the different angle variability is important to us when we are prepping for these patients and figuring out a good UIV. One of the studies proposed that optimal postoperative alignment based on the UIV femoral angle. This number that they gave was that it should be less than 11.5 degrees, though this is dependent on pelvic tilt. So it's a little bit of a moving target, but it does offer some insight into compensatory changes. So again, this UIV femoral angle of 11.5 degrees or lower can give us another target when we're trying to prevent PJK. So this was another study apparently discussed at IMAS a few years ago, and this involves tethers through the spinous processes at and above the UIV. There's about 15 studies that exist, with most of them using different variations of this technique. And the idea is basically to use soft tissue tensioning to create a smoother transition between instrumentation and then the native ligaments. Finite element modeling here suggests that there's some better stress distribution with more levels tethered, but of course it comes with the con of requiring more exposure, and therefore you may reduce some of the stability that you have there. Tightening methods vary. Some pull it manually, some use the ratcheting tools. But despite the variability of this, most studies did show some promise in reduction of PJK rates. And here you can see the range of PJK rates, and generally reported between 20 and 40%, though some of these studies actually report 0% at 2-year follow-up. So this may be a good study to go through and look at all the different papers that they cite. And so here's a very important paper, as we've kind of progressed in our thinking of deformity and PJK. Mike Kelly has given a talk, which I'm sure you all have all seen. Basically, we can't just categorize things, categorizing things, PILL of, 12 or 9, we basically can't categorize things, and we have to make it a little bit more of a spectrum. And so that's how the advent of the Russo-Lee classification came about. And it really does a very good job at showing us the spectrum of spine shapes. And by really understanding these spine shapes, we can get a better idea of how this patient should really be standing. Because, maybe their PILL needs to be higher, their PILL needs to be lower. Um, and we just can't say, oh, we got to get the PILL less than 10 degrees. Rather, we have to understand where the distribution of lordosis must occur, where should their apex or inflection point occur, and kind of reconstruct them to where they need to be based on their Russelli shape. I thought I had the shapes here. I don't know what happened, but if you look up Russelli classification or Russelli shapes on Google, you'll appreciate this. And basically, it is 4 different shapes based on, you can do PI, but I think it was first described using sacral slope less than 30 degrees. If it's less than 30 degrees, you're going to be in the type 1 or 2 group. If it's greater, it's going to be more of a R3 or R4 shape. So again, understanding that is important. And here, we always want numbers, especially when we're in the operating room. We want to know, hey, how can I get this right reliably and make it reproducible? And so this T4 L1 hip axis is indeed a very helpful tool. Again, from the mean study, they use asymptomatic patients, and they found that L1PA and T4PA had a very narrow distribution of values. And so oftentimes, and sorry, for those of you who don't know, L1PA is basically just a line or an angle from L1 to the femoral head to the middle of the sacrum. This is any kind of vertebral pelvic angle. And this.
And Gautham, they weren't asymptomatic. They were non-diseased patients.
Right. Yeah, you're right. You're indeed right. It's asymptomatic, but yeah, it's supposed to say, yeah, not degenerated subjects. Yeah. Yeah. Sorry. This was prior, not this study itself, but other studies looking at sagittal plane did include asymptomatic, but their downfall was that they were degenerated subjects. But this study was one of the first to kind of identify a non-degenerated subjects. So again, L1PA, T4PA can be a very good tool, particularly when you're in the operating room. You get a flat plate, and you can actually measure this on your PACS after they upload it, and say, hey, is my L1PA kind of close to where I need it to be? And it definitely gives you some more clarity and hopefully some calm when you're leaving the operating room. Another simple way when evaluating these patients that Dr. Hills actually taught me was that if you draw a straight line from T4 to the femoral heads, that you should kind of basically bisect L1. And this is another nice way of just giving you a sense of, hey, is this alignment close to where it should be? And again, this is a slide from a prior talk from Dr. Kelly, kind of going over some of these important topics. So definitely a good video to watch, which is on our San Diego Spine YouTube site. So yeah, the goal is to better understand optimal alignment, and undercorrection still leads to compensatory mechanism, which once exhausted will lead to adjacent segment disease. And then again, overcorrection is also problematic because it increases the PJK risk. So we realize that under or overcorrection is really not acceptable, and we have to be pretty diligent about getting our alignment to a pretty narrow margin. Otherwise, we do indeed risk failure. For number purposes, your L1PA typically, if you like numbers, should be half of your PI minus 20. Again, you'll see that in Dr. Kelly or Dr. Hill's talk on our San Diego Spine site, but it just gives you a nice quick calculation to give you a ballpark of where your L1PA should be. And then, of course, T4PA should be nearly the same. And again, when deciding who to intervene on or when to intervene on, this is the hard part, right? Because sometimes we have these patients with a little bit of PJK or a little bit of failure, maybe a little bit of pain, but not a whole lot. And I think that's the art of spine surgery, and in what we do is, how do we manage these patients, and how do we mitigate some of the risks that are associated with revision surgery. So as we know, many patients can be asymptomatic, but the thing is, early intervention may be easier due to less scarring, more flexibility, and perhaps a simpler osteotomy. We do know that most PJK occurs within 18 months. One study of 57 PJK revision cases showed 47% had surgery within 6 months, some due to trauma, representing a different subgroup. And combined anterior-posterior approaches may increase revision risks, though this doesn't account for the preoperative alignment. Greater degrees of surgical correction, of course, are associated with higher PJK rates, but again, this may just reflect patients who had worse preoperative sagittal balance who are kind of returning to their baseline alignment. Another study evaluated PJF revision patients without neurologic symptoms. Those with bony failure and high proximal junctional angles around 22 degrees had a 63% revision rate. So monitoring PJA angles or PJA changes could also help determine a surgical need. The GAP score, we know, is another measure of global alignment, but validation is indeed lacking. Several studies showed that it did not really predict surgical need, and these scoring systems, do need a little more work, and there is no gold standard just yet. So, in conclusion, PJK is still a major problem. We are indeed getting better with the work of, the attendings here and the attendings across the nation, particularly ISSG research. There's just so much being done to better understand this important problem for us and hopefully get us better at understanding what we can do to mitigate this devastating complication after all our hard work and after all this planning. And I think industry is also doing a good job at this, helping us plan better. There's several software planning tools, and I'll be curious to see where AI takes us at streamlining this process and making it better for everyone, really, and making this definitely more reproducible. Again, preoperative planning and technology-based simulation are key advancements, and I want to end the slide. You can guess who this is. Even though it's the arch nemesis of the deformity surgeon, with constant learning and perseverance, maybe we can put an end to this problem. So here's a AI-generated Mundus gladiator. All right, y'all. Thank you. You look pretty good, Dr. Mundus.
I think that's how my
wife
wife
actually looks. 6 packs to scale.
That does look like my patients too. That's great. Yeah, great job, Gautham. That's a definite challenge for us, right? Right. And the crazy thing is, if you look back at the papers, from outside of some of the tethering papers and like some of the work done, I know Chris Ames is feels that his PJK rate's gotten like dramatically less. But outside of that, there's not been a huge bump in things getting better. I know Larry says that he hasn't operated on a PJK for over a year or like 2 years or something like that since he started using, his recontoured, the physician-specific rods,
Yeah, it's because nobody can afford a second operation with him.
Yeah, I think there is some bias. I think there is maybe some bias in there, but guys I think in their practice, like for a while, my rate dropped way down, and then, the law of averages kicked in, and we had 3 or 4 in a row where we had issues. So it is interesting to see like those things occur. So I would say the other take home point, like if you're doing any deformity in your practice, like be really critical of yourself in a learning kind of sense. Don't chalk it up to numbers and say, hey, it's happens 20 to 40% of the time. It's just it's just part of it. Like you need to take the time and try to find the root cause, because it's going to be individualistic to that, right? It'll be individual to that patient. And if you can make notes during your cases on, sometimes when things don't go exactly as planned, if there's a, whatever, a proximal ligament violation, or if you had difficulty with the screw at the UIB, or sometimes you'll find that it's like the little nuance that ended up causing the problem later, and you didn't think that you needed to do anything at the time, but maybe the right answer was that you should have gone up a level right then and there, or, maybe you should have tethered right then and there. I don't know. I'm just thinking like that. But those are the thoughts you're supposed to have as you're operating and trying to make decisions real time. And then you're right. Sometimes it's just
It's also about before you operate, right?
Yeah.
There's a lot of modifiable risk factors. We talk all about the alignment. There's a big host issue.
Yeah.
And if you're inadequate at preparing these patients or recognizing that they're high failure risk, then it doesn't matter what you realign them at.
Yeah.
You could hit their perfect target and you're still going to fail.
Right.
Because they got a horrible osteoporosis you couldn't treat, or they're horribly sarcopenic or malnutrition. The factors that go into the failures are probably broader than we can capture in our own minds and really weight properly. But do your best. At least try to cover the bases before, during, and after the operation.
Right. One thing, and I maybe have to look at the literature, but has there been like a personalized pre-operative rehabilitation protocol for patients undergoing deformity surgery to perhaps address the issue of?
I mean, rehab. Yeah, we send everybody for that.
I wonder are they just doing core strength? I wonder
That's
specific protocol for strengthening our extensors and things like that.
Postural.
Because like for joints, almost everyone goes into preoperative prehab, basically addressing flexion extension of their knee and things like that, which correlates to postoperative range of motion. And I'm just wondering if there's a specific protocol addressing these extensor musculature for these deformity patients.
Probably not to your point, that is as refined as it should be.
Yeah. Because that could also help them hold up.
Yeah, I mean, we send them for extensor strengthening and postural strengthening. But there's, I'm sure, a great deal of variance in what they actually get. I'm sure a lot of them just get ice and stem and heat and little massage. But I don't think there's this uniform protocol that everybody gets when they go to any therapist.
Right.
You're subject to the variance in therapy acumen and the networks constrain that, right? You can't send them to the same physical therapist every time.
Right.